In fluid-producing organs like the prostate or salivary glands, clinicians categorize cancer using a logical system, the specific anatomical site where the tumor originates. This site of origin classification provides a reliable correlation with long-term patient survival, allowing for highly predictable clinical outcomes. Breast cancer nomenclature, however, relies on a different framework, the ductal-lobular dichotomy. This terminology is built on the gross features and cellular morphology of the tumor, rather than mapping the malignancy back to its structural starting point in the breast. Prioritizing morphology over anatomy limits the precision of clinical management. It obscures the biological behavior of the disease, making it harder to assign specific targeted therapies. This reliance on morphology is a product of 19th century limitations. Pathologists at the time were restricted to analyzing large, palpable tumors using flat, two-dimensional thin-section histology. From this two-dimensional perspective, unfolding lobular structures, the acini, appeared to be small ducts. This misinterpretation led to the term ductal carcinoma in situ, or DCIS, being applied to processes that were actually lobular. The widespread adoption of high-resolution mammography screening has changed this landscape, enabling the detection of non-palpable tumors in their earliest phases. Professor Laszlo Tabar and his team have used these early detections to argue for a transition. They propose replacing the ductal-lobular dichotomy with a system based on imaging biomarkers. This new framework moves away from traditional two-dimensional microscopy to instead utilize large-format, three-dimensional subgross thick-section analysis. Viewing the breast in continuous three-dimensional space demonstrates that these cancers arise from three distinct, mappable anatomical origins rather than arbitrary cellular patterns. Approximately 75% of all breast cancers originate from the terminal ductal lobular units, or TDLUs. The proposed terminology for these tumors is acinar adenocarcinoma of the breast, or AAB. Within the TDLU, we can identify the exact acini where the cancer first develops. In grade 1 in situ AAB, cancer cells produce a proteinaceous fluid containing samoma body-like crystals. This chart correlates mammograms with pathology. Powdery calcifications on the left correspond directly to fluid-distended acini on the right. Conversely, in grade 2 in situ AAB, necrotic cell death creates a distinct biomarker, crushed stone-like pleomorphic calcifications. Currently, both of these acinar processes are grouped under the label DCIS, while invasive versions are categorized as invasive ductal carcinoma. Mislabeling them as ductal obscures their acinar origin and masks their localized, predictable progression. The second anatomical site of origin is the major lactiferous ducts, which account for about 20% of breast cancers. Tumors starting here are termed ductal adenocarcinoma of the breast, or DAB. These tumors are defined by a specific, aggressive pathological process called neoductogenesis. During neoductogenesis, high-grade cancer cells originate in the major ducts and form multiple, branching, cancer-filled channels that spread through the tissue. This large-format 3D histopathology image shows the resulting architectural distortion. The branching DAB creates a massive tumor burden that deviates significantly from healthy ductal structures. Applying the label in situ to neoductogenesis misrepresents this invasive growth as a contained precancerous condition. These images show that DAB often lacks mammographic calcifications. Instead, the disease reveals its extensive lobar distribution through architectural distortion or contrast-enhanced galactograms. Using the catch-all term DCIS for neoductogenesis downplays a potentially lethal pathological process. The importance of site of origin terminology is best demonstrated by survival data. This graph compares disease-free survival of two prostate cancer types. The top line tracks acinar origin, while the bottom tracks ductal. Patients with ductal origin face a significantly poorer prognosis and higher fatality rate than those with acinar tumors. Decades of data from the Dalarna County Screening Program in Sweden show this same divergence in breast cancer survival. Small unifocal acinar tumors, or AAB, are associated with exceptionally high long-term survival rates. Conversely, similarly sized tumors exhibiting neoductogenesis are responsible for a high percentage of breast cancer fatalities. A nomenclature system that cannot distinguish between high survival acinar disease and high fatality ductal disease is no longer clinically sufficient. Replacing the ductal-lobular dichotomy is necessary to prevent critical errors in patient management. Conflating both anatomical origins under DCIS causes two distinct clinical failures. On the left, failing to identify localized acinar origin leads to the overtreatment of AAB cases. On the right, assuming neoductogenesis is in situ leads to the dangerous undertreatment of major duct cancers. Inaccurate terminology carries direct clinical consequences, turning a debate over nomenclature into a primary driver of adverse patient outcomes. Determining the anatomic site of origin using imaging biomarkers should be a routine step prior to surgical intervention. Mapping the specific site of origin bridges the communication gap between radiologists, pathologists, and surgical oncologists. Categorizing tumors as AAB or DAB allows for targeted, individualized therapeutic planning. Adopting this terminology requires a structural revision of the current global staging systems. Precision oncology relies on treating the three-dimensional anatomic source of the disease, rather than the flat shadow of its cellular morphology.